So the last defect today is the double outlet right ventricle, which represents less than 1% of congenital heart disease. In this disease, both the aorta and the pulmonary artery are arising from the right ventricle, with the VSD as the only outlet from the LV. The position of the VSD and the presence or absence of pulmonary stenosis are the basis for dividing the defect, this double outlet right ventricle, into the different types. The first type is the subaortic VSD, which represents 55 to 70% of cases, where the VSD is closer to the aorta rather than the pulmonary valve, and this is the most common type, as we see. 50% of these cases, the subaortic VSD, have right ventricular outflow tract obstruction, so they represent like a fallow type. In 30% of cases, around 30% of cases, the VSD is subpulmonic. Subpulmonic means it's closer to the pulmonary valve rather than the aortic valve. In less than 5% of cases, the VSD is committed to both valves equally. In less than 10% of cases, the VSD is not committed to any of the valves. So according to these different pathologies and the types of VSDs and the presence of pulmonary stenosis, the pathophysiology and clinical manifestations of the double outlet right ventricle presents. First, the subaortic VSD without pulmonary stenosis. It's exactly like a patient with large VSD clinically, presenting with increased pulmonary blood flow, congestive heart failure, and will develop pulmonary hypertension. Cases with subaortic VSD and pulmonary stenosis, what we call fallow type double outlet right ventricle, present clinically exactly like the fallow. Patients with a subpulmonic VSD, what we call Taussig Bing malformation, the oxygenated blood from the left ventricle is directed towards the pulmonary artery mainly, and the deoxygenated blood from the systemic veins is directed into the aorta, resulting in severe cyanosis. Although the pulmonary blood flow is very high, and the clinical picture here is similar to the transposition of great arch. Usually presents with gross retardation, severe cyanosis. Second sound is loud systolic murmur of pulmonary overflow relative to pulmonary stenosis, and ECG shows right atrial dilatation and hypertrophy, right ventricular hypertrophy. Chest X-ray shows cardiomegaly with increased pulmonary vascular markings, with prominent pulmonary artery segments. Cases of doubly committed or non-committed VSDs usually present with cyanosis of mild degree and increased pulmonary blood flow manifestations. Echocardiography is essential to diagnose the features of double outlet right ventricle, with both great arteries arising from the right ventricle, so that the left ventricle has no outflow except the VSD, and there is discontinuity between the mitral and the semilunar valves. During echocardiography, we should properly evaluate the great artery relationship, the size and the position of VSD in relation to the great arteries, and associated anomalies. Other studies, like cardiac catheterization, may be indicated before later stage operations. So what is the fate of these patients if left untreated? Infants without pulmonary stenosis will develop congestive heart failure and pulmonary vascular obstructive disease. If there is pulmonary stenosis, complication of cyanotic congenital heart disease will occur, like the fallow. Patients with Tau-Sig-Bing anomaly are more prone of developing pulmonary vascular disease earlier in life. Patients with associated anomalies will also contribute to a poor prognosis. Management of cases with DORV includes medical management with anti-failure medications as diuretics and ACE inhibitors and digoxin. Surgical procedures includes palliative procedures, either be banned in cases with increased pulmonary blood flow and congestive heart failure, and VSDs are not easily surgically approached. However, whenever primary repair by VSD closure, it's a better choice. Patients with severe PS with undecreased pulmonary blood flow, a systemic VT shunt should be the option of choice until the patient is ready for definitive surgery. Definitive surgeries for patients with double outed right ventricle depends on the type of the pathology. In cases with subaortic or a doubly committed VSD, an intraventricular tunnel between the VSD and subaortic outflow is created by a Dacron patch. It's simply a VSD closure. In cases of fallow type, the procedure may be just similar to a fallow repair by the VSD tunneling and the PS RVUT resection and maybe PS dilatation or transannular patch, or it may be more complex by tunneling the VSD by an intraventricular tunnel between the VSD and subaortic flow, and doing a Rastelli procedure, which is using a pulmonary or homograft conduit, valved conduit between the right ventricle and the pulmonary artery to bypass the pulmonary stenosis. In cases with subpulmonic VSD, what we call Tau-Sig-Bing anomaly, surgical repair should be done as early as possible to prevent the pulmonary vascular disease. In this pathology, the repair is done like the subaortic or doubly committed VSD by intraventricular tunneling, and thus we change the pathology as if it is a transposition of gate arteries. So we go on for arterial switch operation also. This is a very tough procedure, and it carries a risk of 5 to 15% of mortality. This concludes the presentation of the most clinical and most important cases of congenital cyanotic heart you can meet in your practice and how you can manage them. Thank you for your attendance. I hope you have a nice day.